The complexities of fluid management, especially in the setting of hypo and hypernatremia, in the setting of DI and SIADH, are really highlighted by these two cases which we recently encountered in our practice. This was a 10-year-old girl with craniopharyngioma, underwent neurosurgery, and then developed polyuria as part of the postoperative phase, was advised vasopressin infusion, and by the time the patient was referred to us, had already developed seizures with severe hyponatremia. So this is something which is not unusual. This is the classic triphasic response that we see in neurosurgery, and that would result in the SIADH phase and this exaggerated response. Coming on to the other spectrum, there was a 13-year-old girl with tubercular meningitis who was having drowsiness and euvolemic hyponatremia with high urinary osmolality. A diagnosis of syndrome of inappropriate ADH secretion was made, and a treatment with tolvaptan was started. And all of a sudden, around 12 to 14 hours after starting tolvaptan, she started developing abnormal speech. And what was noticed was there was a rapid increase in terms of sodium, and a possibility of osmotic disequilibrium was considered. So disorders associated with salt and water management in the ICU are common, and they may manifest as too much fluid in the form of SIADH or too little fluid in the form of diabetes insipidus. They have a huge amount of diagnostic confusion which is associated, emphasizing the need for careful assessment. So over the next 15 minutes or so, we'll get through the various pathophysiological aspects of electrolyte management with practical tips in terms of difficult situations for management of SIADH and DI. And understanding osmolality and tonicity is absolutely important so as to decide the impact of these disorders and their specific treatment. So we all know that the three major determinants of osmolality are sodium, glucose, and urea. However, urea is not an effective osmol because it passes through the plasma membrane equally, and therefore the tone of the plasma is largely maintained via sodium and glucose. Situations associated with increased tone will result in extrusion of fluid from the cells, causing a shrinkage of the cell, predisposing in the setting of diabetes insipidus towards intraventricular hemorrhage, while those associated with a decrease in tone will result in fluid coming into the cells, causing a fluid swelling and cerebral edema in the setting of SIADH. Now, to avoid these complications, there are adaptive mechanisms which the neuronal cells play an important role, particularly the development of pedogenic osmoles, and they essentially are able to maintain the homeostasis. Now, in situations where the treatment is suddenly done and there is a rapid shift which happens in osmolality in the sodium levels largely, we would see in the setting of DI a possibility that there would be sudden edema happening, while in SIADH, because of shrinkage, there could be a minor lysis or what is known as osmotic disequilibrium syndrome. So DI and SIADH represent the extreme spectrum of water deficiency and excess, and rapid fluxes and changes can have dramatic impact in that regards. So going on to the specific disorders and how to manage, especially the fluid electrolyte part, and that we'll start off with diabetes insipidus, focusing on the acute, the chronic, and special management in certain situations. Acute management of DI usually is in the form of hypernatremia. So just an overview of hypernatremia management. We usually aim to correct over 48 hours using the maintenance fluid, using the standard formula of 4-2-1. Free water deficit, which is essentially 4 ml per kg for every increase in sodium over 140, and ongoing losses. The aim is essentially to have around 9 to 10 millimoles per liter per day fall in terms of sodium in acute cases, and a more gradual 6 to 9 in chronic cases. This is usually established via a half normal saline sort of a situation with 120% maintenance, with a close monitoring of sodium and the GCS state. Very importantly, any rapid fall in sodium may result in seizures, and in that situation 3% saline may be effective. One of the most classical example, of course, of The whole process is the neurosurgical diabetes insipidus, which essentially represents a triphasic response of initial diabetes insipidus following surgical intervention because of neuronal swelling, the SIADH phase, which involves the release of the AVP from the neurons which are dying, and finally, if there is significant damage, the necrosis resulting in a permanent DI. Now, in this situation, the treatment becomes very tricky because giving too much fluid may actually result in a problem, especially if AVP is used in the SIADH phase in that regards. Importantly, post-neurosurgical polyuria is not unique for diabetes insipidus. It may also happen with cerebral salt wasting or by giving too much fluid in that regards. So therefore, the diagnosis of this requires the demonstration of a concentrated blood, a sodium above 146, and a urinary osmolality which is below 300 millimoles per liter in that perspective. The management of a neurosurgical patient in which the sellar region has been handled is really important because we want to avoid all these complications. So this essentially involves the administration of half normal saline with 5% dextrose, with compensating for urine output along with the essential water losses which happen, the insensible water losses, with close monitoring of sodium, urine output, hydration, and electrolytes. Hyponatremia in the setting would suggest cerebral salt wasting, the need for fluid sodium chloride, and possibly fludrocortisone. Sodium in the normal range would mean that we are doing well to continue the same treatment, while if the sodium goes above 150, a major issue is whether we are dealing with hypovolemia. In that case, if the urinary osmolality is high, suggesting dehydration with the fluid rate has to increase, or diabetes insipidus in which the urinary osmolality will be low, in which the management will require fluid or AVP. So we have a 12-year-old boy post-sellar surgery. The sodium is 151. Vasopressin infusion was advised, but what we need to really look at is what is the exact diagnosis. So we have this child who has hypernatremia. We have to look at urinary osmolality, which is high, which clearly indicates that there is hypovolemia and there is a need to increase fluid rate. So this clearly would be inappropriate in this setting to start vasopressin. We have a 10-year-old girl with craniopharyngioma with sodium of 156 with polyuria, going more towards diabetes insipidus. The sodium is on the higher side, the urinary osmolality is low, confirming diabetes insipidus. So the management here would either be fluid or AVP, and this itself is an important issue. So let's see what happened in this case. Was the vasopressin infusion, as discussed in the first index case, was started, and this resulted in hyponatremia and seizures. And this we discussed was basically because of the release of AVP already from the dying neurons causing that SIADH phase, which is very important. Highlighting the fact that giving AVP in this setting was probably not preferable. So how does one treat acute central DI? The options of treatment include the use of fluid alone or the use of AVP. The maintenance fluid could be the standard for both these cases, 40 ml per meter square, while for fluid alone we use N/4, for AVP we use normal saline. The urine output is of course replaced with 5% dextrose if it's above 40 ml per meter square per hour, with fluid alone with no replacement with AVP, with a ceiling of 120 and 40 ml per meter square per day. So what we are actually doing in the setting is that on one hand, we are actually giving a lot of fluid to correct, to ensure the urine output is being replaced, while on the other, we are giving AVP to reduce the urine output production while we are replacing a minimal amount of fluid. The problem of fluid alone management is that there would be a risk of dehydration and hyperglycemia, while if we give AVP, as we saw in this case, there is a risk of hyponatremia during the SIADH phase. So we need to balance both of them to achieve a good outcome. And in most acute cases, especially neurosurgical, fluid alone therapy would be beneficial. But what if whatever you have done, the goal has not been achieved? Ideally, one would like to have a gradual fall as discussed, depending upon the severity of hyponatremia, maybe 9 to 12 millimoles per day. But if you have, by chance, somebody is given desmopressin and there is a rapid fall, there is seizures, what to do? So in this setting, clearly we do not want the sodium to fall, so we should give 3% saline for the levels to go up and gradual correction. So re-increase in the sodium levels is absolutely essential as part of management of acute central diabetes insipidus, provided the hyponatremia is happening in that regards. Chronic management is also very important, and the options of course include the fluid, which has to be more free water, reduced amount of solute with diluted milk, and very importantly, no intake of water, especially if AVP has been started in that perspective. The AVP options include desmopressin, which can be given parenterally, not really commonly, using inhaled or the oral form. The key message here is that we have to start at the lowest possible dose to allow diuresis happening before the next dose, and with close monitoring of weight and sodium. In infants, use of AVP may actually be difficult because of difficulties in terms of excess of water with the risk of hyponatremia, and in that setting, using fluid along with thiazide amiloride may be quite effective. And this is highlighted by this case: a 1-week-old child with HESX1 defect with diabetes insipidus started on DDAVP spray, presented with lethargy and seizures and hyponatremia. So what happened here is that this child was given DDAVP, which had a long duration of action, and that really triggered the overdose, and it would have been more appropriate in the setting to use fluid and thiazides, which will have a better impact in that situation. Now, there could be certain special situations which may alter the management of DI, particularly sick day. So in febrile illness and gastroenteritis, there is a risk of dehydration, and this can cause potentially life-threatening hyponatremia. So we need to ensure that there is more fluid intake. However, giving IV fluid in this setting may be dangerous because already they are on desmopressin, and this will cause decreased urinary water loss, and this may cause fluid overload. So we have to be very, very careful in giving IV fluids in that perspective, and never give sodium content above N/2 because of the risk of hypernatremia. So the same child on follow-up 2 years later presented with fever and vomiting, was admitted with fluid bolus and hydration was given, now developed hyponatremia. This is of course because of not reduction of AVP dose, and this is something which needs to be cautious in that regards. The second situation, of course, is the chemotherapy, which is particularly relevant with renotoxic agent, in which one needs to give a lot of hydration in that regards. Giving too much fluids in that perspective can cause a problem, because then the sodium may be affected and water can go up in that perspective, because the child is already on DDAVP. So what do we do in that perspective? We can do hydration with a low dose AVP infusion. The classic example of this is this 3-year-old child with LCH with DI on chemotherapy, advised hydration, developed respiratory distress and pulmonary edema, and this of course is because AVP was already being given in this situation. So best would have been to avoid. Now currently we have to give diuretic, and then subsequently we have to use low dose AVP with fluid, which will help out in terms of the outcome. Now, fluid management in SIADH is of course challenging, and most of these situations will present to us with hyponatremia. And as we know that the treatment of hyponatremia is guided by the duration as well as intensity. So onset in the first 48 hours with the severe symptoms like coma and seizures would definitely require 3 to 5 ml per kg of 3% sodium chloride, followed by a rise of around 9 to 12 millimoles per liter per day. If there is a mild to moderate symptoms like headache and confusion, sodium over 120, the dose of correction is less, and maybe we can even use an infusion of around 1 ml per kg per hour of 3% saline, which will rise the sodium content by 1 millimoles in that perspective. Duration above 48 hours is considered to be chronic, and if there is no clarity as to how the duration, we should go by symptoms. Severe symptoms with coma and seizures may still require 3% saline, but subsequent rise should be low, while mild to moderate cases with nausea will not require 3% saline and with mild correction in that perspective. So we have an 18-year-old girl with acute intermittent porphyria presenting with hyponatremia, headache. There is no vomiting and seizures, so we are talking about more in the setting of mild to moderate category in that perspective. So we can do some fluid restriction along with a low dose as far as the treatment is concerned. Now, management of hyponatremia involves the combination of maintenance using the standard formula, hyponatremic sodium deficit, and the use of isotonic sodium deficit to calculate with a target rise in acute cases of 9 to 12 millimoles per liter per day and 6 millimoles per liter per day in chronic cases. Close monitoring of sodium 4 hourly is absolutely essential. Very importantly, if there is a rapid rise, there should be relowering in that perspective. The management options in SIADH include fluid restriction to around 2/3 the maintenance that will rise the serum sodium gradually by 1 to 2 millimoles per liter. There is an option of using sodium chloride as an osmotic agent. However, we need to understand that SIADH is largely a fluid overload situation. Even if the patient is euvolemic, there is an increased natriuretic peptide secretion which causes increased sodium loss from the kidneys as well as suppresses the aldosterone production from the adrenals, and both of these conditions favor natriuresis. So as soon as any sodium is given, it is lost immediately in the urine in that perspective. So if one wants to use sodium chloride, it has to be hypertonic saline, then it will drag water along. Vaptans are a popular choice in adults, but in children they can cause very rapid changes in which will cause a lot of problems in that perspective. One option, of course, is to induce a nephrogenic DI like picture by lithium and dimethylcycline, which may be helpful in rare situations. Vaptans are the agents which act on the V2 receptor by blocking the cyclic AMP production. They reduce the resorption of water in the collecting duct, resulting in pure aqueresis. The problem here is that they will cause very rapid rise as far as sodium is concerned, and they should be avoided in children in that perspective. So we have a 13-year-old girl with tubercular meningitis with drowsiness and hyponatremia. Urinary osmolality is 130, was advised tolvaptan by the treating physician, and now around 12 to 14 hours later presented with abnormal speech and vacant stare. So what happened here is that there was a very rapid rise which happened with regards to the sodium level, and that caused what is known as osmotic disequilibrium. So essentially in hyponatremia, as discussed earlier, there is a risk of cerebral edema. To prevent that, there is formation of idiogenic osmoles which essentially maintains the content. A sudden increase in somebody whose sodium was below 120 by more than 10 millimoles per liter per day will result in delayed onset demyelination, resulting in dysarthria and speech abnormality. So what do we do in this perspective? So ideally, as discussed, we want a very gradual rise as far as sodium is concerned. But in those situations like this, where vaptans have been there, sodium may rise rapidly, resulting in altered sensorium. So the option is to give vasopressin and water to bring the levels down. And this relowering is very important, highlighting the need for careful monitoring in the setting. So SIADH and DI are important endocrine emergencies where appropriate diagnosis is essential. We should theoretically avoid AVP and V2 receptor analogs in acute situations in children because of a lot of problems in that regards. Importantly, there is huge variability in terms of response. There is a need for monitoring of fluid and sodium, which is very, very important. All of you can go and have a look at our website, learning.growthsociety.in, where there are multiple resources available with regards to pediatric endocrinology, including this talk as well.